Okay, picture this high-stakes scenario. Your charge nurse tells you to place a PICC line, right now, but you look at the chart and there is no provider order. You gonna do it? Your answer to this specific question matters immensely because it bridges the gap between what you are physically capable of doing and what you are legally allowed to.
Welcome to this explainer. Today, we're taking the kinda dry, complex topics of healthcare law and ethics and turning them into a dynamic, highly practical bedside playbook. If you regularly place midlines or PICCs, consider this a warm welcome to your survival guide for protecting both your patients and your license.
Here is our roadmap for today. We'll be hitting 5 key stops: scope of vascular practice, navigating the consent process, device selection and advocacy, IFUs and legal boundaries, and finally, the ethical clinician.
Section 1, Scope of Vascular Practice. Let's start with the absolute baseline.
First up, we have the standard of care. Basically, this is your ethical and legal duty to provide the exact same level of care that another reasonably prudent professional in your shoes would provide. It's not just some vague idea, right? It's shaped by national guidelines, your hospital's policies, and state board regulations. Think of it as your professional benchmark.
Now, contrast that with your scope of practice, which is determined by your licensure and training. Going back to our charge nurse question from earlier, just because you have the technical, physical skill to drop a PICC, doing it without an order or proper credentials, that is a strict scope violation. You literally have to refuse and document that refusal. That is how you legally protect yourself.
Moving on to Section 2, navigating the consent process. Let's bust the myth that consent is just getting a quick signature. Did you know a signature alone doesn't legally prove consent? Crazy, right? It's actually a full-on educational process involving shared decision-making. You need capacity, disclosure, understanding, voluntariness, and then authorization. You got to clearly explain why the device is needed, plus the risks, benefits, and alternatives. And to really guarantee understanding, use the teach-back method. Have the patient explain the procedure right back to you in their own words.
Check out this focused timeout environment. You're verifying the patient's ID and making absolutely sure that signed, valid consent is actually in your hand before you even think about picking up a needle. This strict protocol is a non-negotiable must before any invasive procedure begins.
Now, crucially, this whole process shifts depending on age. For competent adults, it's a legally authorized decision. But for pediatric patients, while the parents give the legal consent, we have to get the child or teen's assent. This means helping them understand what's happening at their developmental level. You might use age-appropriate teaching aids, like dolls or stuffed animals, to explain the IV in a completely non-threatening way.
Of course, there are exceptions. We legally have to know when implied consent takes over. In true emergencies, if a patient is totally unable to consent, say they're unconscious, and delaying care would cause immediate, life-threatening harm, well, implied consent applies.
Section 3, Device Selection and Advocacy. Let's look at why prioritizing patient well-being here is one of your most vital ethical duties.
You should constantly be running through this mental checklist. What's the therapy? Is it a vesicant? How long are they going to need it? What's the pH and osmolarity of the meds? And finally, what do their vessels actually look like? We use this clinical reasoning tree to figure out if this patient genuinely needs a central line or if a less invasive device, like a midline, would do the trick safely.
When comparing the two, the distinction between a PICC and a midline is huge for patient safety. A PICC ends in the central circulation, giving you high blood flow to dilute harsh vesicants or TPN. A midline is peripheral, so no central dilution. You absolutely cannot use a midline for vesicants or TPN. Nailing this difference ensures you're working safely within your scope and preserving the patient's vessels.
Okay, let's look at a real-world scenario. You've got a 65-year-old with stage 4 chronic kidney disease who needs 3 weeks of IV antibiotics, and the provider orders a PICC. What happens if you blindly follow that order? Well, you risk ruining their upper extremity veins, which they desperately need to preserve for a future dialysis fistula. Evidence-based guidelines dictate that you step up, advocate for the patient, and recommend a midline or alternative access instead.
All right, Section 4, IFUs and legal boundaries. We really need to talk about the strict legal binding of manufacturer instructions for use.
Here is a hard truth for you. Manufacturer guidelines aren't just polite suggestions, they are legally binding. Ignoring maximum PSI ratings for power injections, using the wrong flushing volumes, or pushing incompatible locking solutions, that strips away your legal protection. If you power inject a PICC above its rated pressure and that catheter ruptures, the liability falls squarely on you.
Now, we all know sometimes clinicians use devices off-label. While off-label use isn't strictly illegal, you are walking a very dangerous tightrope. It absolutely requires an explicit provider order, a rock-solid risk versus benefit justification, incredibly clear charting, and full institutional support. Without those 4 things, you are way outside safe legal boundaries.
And understanding liability brings us to the 4 elements of malpractice. To be found negligent, you need a duty of care, a breach of that duty, actual harm to the patient, and causation linking your breach directly to that harm. So, if you breach your duty by breaking sterile technique during a PICC insertion, and that specifically causes a central line-associated bloodstream infection, all 4 elements of malpractice are met right there.
Finally, Section 5, the ethical clinician. Let's tie all these legal rules back to the core ethical identity of a true vascular access clinician.
Let's swap the academic jargon for bedside reality and see how these 4 ethical pillars actually apply. Take autonomy. If a competent adult patient is terrified of pain and refuses a PICC line, you must respect their preference. You educate, you explore their fears, you document it, but you cannot force it. Beneficence means always acting in their best interest. And non-maleficence? That means aggressively avoiding harm, like pulling a line the absolute minute it's no longer medically necessary. And justice ensures fair and unbiased access to safe care.
And hey, if you think ethics is purely about bedside care, think again. Fiscal responsibility is a huge part of ethical practice. We're talking accurate charge capture, not ripping open expensive PICC kits before you fully confirm the patient is a candidate, and definitely avoiding central lines when a simple peripheral IV would work just fine.
It all boils down to this: efficiency is ethical. Your documentation, logging those specific IFU details, the consent process, your clinical rationale, that is your ultimate legal shield. And above all, advocating for the safest, most appropriate device for your patient is your highest duty. Every single decision you make impacts both patient outcomes and your own professional integrity.
So, I'll leave you with this. Take a hard look at your bedside routines tomorrow. When you grab that ultrasound probe, are you genuinely acting as an ethical advocate, or are you just following orders? Remember, your daily habits protect your patients and your license. Keep learning, keep advocating, and I'll catch you on the next explainer.